Good morning, everyone, and thank you, Camilla, for that nice introduction. So I'm warning you before that I am not a pure scientist. I'm a clinician who work with scientists, and I learn from their work. You've seen yesterday the fantastic presentation of the leading edge and hot topics in bench and how that can be translated to our bedside, which all purpose of our work is to help our patients. So you see, this is kind of strange objectives, but truly these are the daily life for me. I say that my aim in my practice is to use the bench research information from the scientists like we saw them yesterday on their presentations, and in difficult cases to be able to think out of the box in order to help the patient, especially when the standard of care doesn't work. So there are a few possibilities what is wrong. Either our patient is atypical, or I am not thinking right, or there is something that we both don't know. So it's important to be open to that concept and how to use translational medicine for patients' care for existing research data. So first of all, I want to really thank you, the organizer of the Magnus Group and World Congress in Infectious Disease. I think this is a fantastic venue that we can gather all people with various expertise to come together, and some clinician like me who comes here and learn and take home the messages that can help our patients. So in order for me to move forward, I need to give you a real world scenario that how this all started. A 42-year-old woman with systemic lupus erythematosus, who also happened to be the sister of one of our lead nurses in the hospital. So, you know, those things always make you a little bit more nervous because you're going to see her sister every day at work and you don't want to strike out. So I come at around 10 o'clock at night to see her because one of my colleagues, who is a world researcher in tropical medicine, trained in Canada, US, Oxford. So she is 1 foot in Canada, 1 foot is in UK, 1 foot in Hong Kong and Thailand. So she wasn't around. So I got called to come and see her. And I find that her story is very interesting. I'm not certain I can find out what's going on because a world leader before me saw her and she is still having problems. So what were her problems? Her problems were that, that she had a number of years presented with, especially the last 2 years, with cough, fever, pleuritic chest pain. Everyone thought this is just lupus and she's not responding optimally. She was Canadian born, but she was South Asian descent. So that definitely was a point for me to think about what maybe why she's not responding, because the treatment she was on was right. So she had a history of similar symptoms in the preceding 2 years, was getting antibiotics, prednisone, not getting anywhere. And that was even more stressful for me, that I'm coming into a huge situation and I'm trying to help. So I come to the room and I see that not only she is there, her sister, her husband, and all the family member standing there waiting for me to pass the last goal. You've seen Messi in the soccer game when he come to, I felt like that. Plus I had a big possibility that I may not be able to solve the problem. So her laboratory findings were high white count, high CRP, and her growth of bacteria was Mycobacterium avium complex. And it's from the chart, I found out that in the last 2 years, she's having this positive every 6 months, despite being on and off on treatment. And when I looked at her, she was sick looking. She had fever, she was unwell, her white count was 28,000, her CRP was in 200s. And her alkaline phosphatase was elevated, which always indicates to me that MAC is disseminated because it's very sensitive to alkaline phosphatase. and her sputum was positive. So what was going on with her? I look at her CT, and that was her CT scan. As you see on the left lobe of the lung, left lower lobe, this consolidation was persisting no matter what she was given. And she was on the right antibiotics in the past. So why she was not getting better? Any thoughts? That was my last thought. But initially, we were worried about other things going on. Is it just lupus is getting the situation more difficult? Is it cancer? Or there is something, the immunity, which, you know, was a possibility. So we, a CT scan, a PET scan was ordered for her. And that's how the presentation was. As you see, there is light up in the area of hilar lymph nodes into the vertebrae, into the bone, and some on the axillary area, which here on the lymph node, and some of it in the lungs, which you already seen. So they said that let's go and do a biopsy. That's always is the best, right? Direct biopsy, see what's going on with the patient. So we did, and it's not moving. Sure. Either the battery is low or got stuck. So on the computer, yeah. That's it. Oh, thanks, Camilla. Yes, Camilla solved the problem. Yeah, thank you. So lymph node biopsy showed lymphadenitis with abscesses, and something was very interesting. They could not see any granuloma. So she was South Asian descent. She had lupus, and she had no granuloma on the biopsy. So what the biopsy showed, if you look at here, you see that on the top portion here, there is no granuloma, but you see on the bottom part, there is granuloma. Granuloma is normally seen, but the top one was her biopsy. So whatever she had could not create granuloma. So that was a third key for me. So I had to scratch my head. I was not smart enough to diagnose right there on the bedside. So the biopsy grew Mycobacterium avium complex again from the biopsy, not the sputum. So that really made us very certain that's what we were dealing with. For histopathology was no malignancy. And then the fourth evidence was obvious. Her IGRA was indeterminate. So it was very interesting. And her PCR also was positive. So really came down to this is what we are dealing with. But why she is not feeling better? She is getting all her treatment. And what happened, again, we started the new treatment, which is triple therapy, and rifampin, ethambutol, and clarithromycin. About 2 weeks into the treatment, she developed a rash, which is unfortunate. It was very characteristic of rifampin rash. So we had to stop rifampin. There are evidence that disseminated MAC can be treated with dual therapy. That's coming from the HIV study 30 years ago. So we thought, okay, adding moxifloxacin or stay on dual therapy, because she was very complex, we stay on dual therapy. But she was not getting better after 3 months. So eventually we thought, you know, could this be gamma interferon antibody syndrome positive? Something that affects people with South Asian descent. It can affect people who are under 40s or 50s. They don't look like they are having any underlying immunodeficiency. Why? Because your TNF, tumor necrosis factors, are low. Anytime you do not have TNF in the system, you do not show wasting syndrome. That's why these people look very normal looking, but they do have this big problem. And when that will manifest, when you have a chronic infection, because they cannot clear intracellular organisms. So now we have only one lab in the world who can do the test. And we cannot start the treatment without having that test result back. And as you know now, that lab is under scrutiny by the new administration in the United States, and they are threatening with their funding. And we are told that they may not be able to accommodate us for further testing. So you see, situation is not that friendly. So at that point, we were lucky. That was a year ago. So we tested, and the test came back positive. So I suddenly became very famous there, and we started our own treatment. And here is after 3 months of treatment, you see almost 70% of the consolidation is resolved. Just for you to remember, that's how it was before the treatment. And 3 months after treatment, there was no change until we gave her the treatment for this underlying immunodeficiency that we're going to discuss. Yes, we're going to talk about. Just need patience. Yes. So for me to understand really where the problem is, I had to review all my medical school notes again. What's the immunology? So as you all know, I'm talking to experts here, but just want to review, put you through the real scenario. We have 4 compartments in our immune system. The first one is anatomical and chemical, which is a continuous barrier for infection not to get in. Your skin, your tears, defensin, anything you can, mucosal and epithelial with defensin secretion, they will prevent and always protect you. They are your cheap bodyguards. Then, if the bacteria continue to come in, then you have your second system, intrinsic system, which has intelligent system for your immunity. That produces alpha and beta interferon, but not gamma. So alpha and beta causes apoptosis, cell death program, which we talked about, autophagy, microRNA, and cluster segmented repeat molecule, which they all go around through the ribosome and defend the body, destroy the cell. And if that doesn't work, then you write a letter to the higher level of the immunity in your system, which is called, which is basically innate immunity. And that has natural killer cell, your complement system, your antigen presenting cell, and neutrophils. Then, this is not very friendly with me, but let me see here. Okay, got it. So, and then if that takes about minutes to hours. So they're very fast, brisk, swift, they come in. And if that doesn't help and you're still having that organism, which is like mycobacteria, persist inside the cells, then what will happen? They go to the last part. So this part called innate immunity, but then we go to adaptive immunity. Adaptive immunity is a highly specific specialized cells, which in that case, your specific T cells and B cells are equipped with program and genetic enhancement and protein and cytokine production, which go after the organism to kill it. And here is that your gamma interferon play a major role. So we thought this lady has problem with interferon. So there are 3 major problems with interferon. Either you cannot produce interferon. Usually you see that in HIV or very advanced patient with significant immunodeficiency that they showed in a very childhood period. So that wasn't her. So we put that one out. The second, maybe the mutation in the receptors that doesn't allow interferon attached to it, but it's not very common. So the third one you're left with is autoantibody against this interferon gamma. And if that happened, and here we can see how that happens. So assuming on the left side, you're having dendritic cells which got introduced to the mycobacteria. What happened? It produces interleukin 2 and interleukin 12. Interleukin 12 enhances the naive T cells and make them activated T cells. So they become experienced because now they have seen the enemies in the house. So what they do, they produce interferon, gamma. So gamma interferon only produced in the cells that they are infected. When they are not having signs of infected, they will not be produced. However, receptors remain in many cells, cell wall. Then gamma interferon attaches to the receptor, and what will produce, by attaching interferon to the receptor, you giving signals to the cells through two systems, JAK and STAT. What JAK stands for is Janus kinase, and when STAT for is signal activating transcription. So by producing that signal, you enhance a lot of gene to be activated and produce a lot of cytokines and go after the intracellular organism in a normal situation to kill it through different mechanisms. And it is HLA related. So we believe in some South Asian descent, this HLA polymorphism does not allow the gamma interferon to work because they produce autoantibody. Why it triggers, we still don't know. Is a viral infection? Was it lupus? Was something? But that's what it happened. So that was our hypothesis. So then what happened? Well, you look at on the left side, you see the pink is your gamma interferon, and the green is the antibody attaches to. So what happens? That interferon can no longer to be active on the receptor. So when that doesn't happen, means that you do not have any intracellular signals. When you do not have any intracellular signals, what happens? Your cell cannot kill the mycobacteria. As a result, that persists. Is not a recurrent infection that we thought 20 years ago. This is persistent infection because they do not have the ability to destroy the organism. So what is very important for you to remember, the role of interferon gamma and interleukin 12. There is a link. Those who are microbiologists, they know about this more than I do. Many diseases, you get recurrent or persistent salmonella infection. There could be a link of problem between interferon gamma and IL-12. So it's very common, but in this case, either you have deficiency on your receptors or you have autoantibodies. When that happens, your low interferon gamma and interleukin 12 result in low TNF. So you do not have any wasting syndrome. These people look perfectly normal, but they have this problem when they encounter with this mycobacteria, they cannot kill it. As a result of that, they have persistent intracellular organisms. So what are interferon? Interferon are a large group of proteins, which we call them cytokines, and they have three different types of interferon in the body, alpha and beta. Those are the ones that they are very immediately contribute to the immune system defense. They cause autophagy, they cause apoptosis. But what we are worried about is the gamma interferon, which if that doesn't work at the end, you cannot cope with sophisticated infections like Mycobacterium avium complex. And as a result of that, unfortunately, it creates some genes that while they're trying to kill the bacteria, but they are also deleterious to the host, meaning that the host develops fever, chills, flu-like symptoms. You recall when we were treating hepatitis C with interferon and ribavirin, how sick patients becoming because of these properties of the interferon. And they express a lot of genes, and these genes, while they're trying to kill the bacteria, also make the host very sick. But at least it's good to have it than not to have it, because then you can never clear the infection. Apoptosis. Apoptosis in a cell death program. When you have an infected cell, the mother nature creates a program that cell eventually gets fragmented and swallowed by macrophages. So they think gamma interferon also contribute to that, or alpha and beta. So here is the mycobacteria gets into the cells. You need your receptor to work. You do not need to have mutation. You do not need to have autoantibody. When you have those into the system, then you know that you cannot have signaling. So what is that signaling does? It's very simple. Remember, there are two gamma interferon receptor, 1 and 2. So we have JAK1, JAK2, and then they both signals STAT, which is the signal signal transducer and activated of transcription. Therefore, the producers get all these genes activated and produce cytokine. When you can use that receptor, you do not have any defense, and that's why it happens. It also applies to autoimmune disorders, apply to the cancer patients. So there are 3 principles for this you need to remember. That's your take-home message. Chronic infection like non-tuberculous mycobacteria, Cryptococcus, Histoplasma capsulatum, Salmonella, Burkholderia. If you have this problem, you will not be able to clear. Unfortunately, majority of cases are diagnosed 18 months after their presentation. In our patient was around that time as well. So, and then symptoms they present with is peripheral lymphadenopathy, as she had, lymphocytosis, lymphopenia, and high CRP. And these are the clue plus her South Asian descent, despite she was Canadian born. She had that HLA polymorphism. And Mycobacterium tuberculosis get mixed up with this. Lots of time, these patients are diagnosed with Mycobacterium tuberculosis, but it's not the case. Where is the clue? Your IGRA test, the gold gamma interferon assay, are indeterminate. So that's another clue that you can diagnose. So the last 20 years, we are having more of this, and then the antibody is really globally affecting, and it's interesting. If you are living in Taiwan or Thailand, you're having more Mycobacterium abscesses. If you are living in North America, Vancouver, where I practice, which we have a lot of South Asian descent living there, as the immigrant students, we are seeing a lot of Mycobacterium avium complex. Why these are different, we don't understand. Maybe just the environmental factors. So, and your gamma interferon are indeterminate, and the treatment, answering you, madam, is rituximab, that we think is the best treatment. There are other treatments as well, CHOP therapy, cyclophosphamide, daratumumab, which is one of the biological, but to our experience, that the experience was rituximab. You give once a week for 4 doses, and it's a miracle drug, and it will change. And where does it work? I'm gonna share with you. So these are repetition. I'm not gonna repeat it again for you because I'm talking to a bunch of smart people, and they present late in life. And be careful, your patient otherwise look fine, normal looking, but when they encounter to atypical mycobacteria, that happens. The epidemiology, as I mentioned to you already, they have this Mycobacterium abscesses in different parts of the world. In North America or MAC. And we also, this case been reported now from Japan, from South Africa, Europe, Southeast, so it's everywhere. So it's not just happening to us there. So that's why I really wanted to share this with you. There is an association with HLA system, and in our region, female are dominant, but interestingly, you go to Taiwan or Thailand, there is a equal distribution in gender. So why is that again? I don't have the answer for you. So it's very important we be able to test this, but unfortunately it's not easily available. How about gamma interferon receptor mutation? That also is another problem, is less common, fortunately. And with that, what we see, if there are problems not on autoantibody, but on the receptor side, again, interferon, gamma interferon cannot attach. Therefore, you will left with chronic abscesses. They just stays there. Whatever you do, you give antibiotics, they are not going to clear them. And rituximab doesn't work in receptor mutation. The only thing works is bone marrow transplant, which is very heavy things to be done for it. Unless they are children, they will not be able to offer it. So, and as we talk about, because they don't produce low interferon, IL-12 produces low TNF, therefore they don't have wasting syndrome. Their growth is normal. This is another sign. How do you diagnose? With ELISA, and flow cytometry. And this way you can confirm first screen and then you confirm. And that's the only lab that is done is in NIH. And this is my good friend and colleague, Dr. Stephen Holland, who discovered this problem. And he sent me an email, said, yes, please, for now, you put on hold for sending me this test because I lost my funding, which is very unfortunate. So how does rituximab work? Rituximab attaches to the B cells through a receptor of MSA41. And as a result of that, they deplete the B cells through CD20. And when your B cells are depleted, they will not produce this autoantibody against interferon. And that is the mechanism. And there are other treatments like cyclophosphamide, but nothing works like rituximab. It's a magic medication. So in conclusion, these are patients that we have two types of gamma interferon deficiency, not because of not having it, because you only see it in HIV, but in non-HIV population, you have to be thinking about this. And we do know that the study and research shows that the only problem and pathoimmunogenesis is the presence of these autoantibodies. So we have to get that one out of the way. And in order to do that, you need to order it and test and confirm. And when do you think about this syndrome? Now let's review this as your take-home message. You are all, most of you are clinicians. You came here to get some take-home message. This is my little corner part take-home message for you. If you see this patient, you're thinking about this possibility because you can't send the blood for everyone. When they have pretest likelihood is high, they have a disseminated MAC, but you're surprised. There is no reason for it. Patient is not HIV positive. Patient is not transplant patient. Patient has South Asian descent. Wow, how did that happen then to her? Why is that? Because they have an HLA polymorphism that may be triggering their autoantibody syndrome. And then they don't have HIV or other immunodeficiency. And also, when we look at the pathway, they have history of recurrent infection in childhood. They say, I was keep getting a viral infection, herpes infection, genital, oral, all of this, fungal infection. Those all are the clue when you look at the patient's previous chart. And their quantity interferon tests are indeterminate. It's not positive, it's not negative. That's another clue. How do you manage? Well, in a regular and ordinary situation, you give them the antibiotics. But if the antibiotics doesn't work, you got to think about this syndrome. If they have the other things that I mentioned to you, in that case, you give rituximab. This is the dose, 375 milligram per square meter. You give once a week, 4 weeks in a row, before you give the antibiotics. This is very important, before you give the antibiotics. And with that, I didn't even let you come to the so thank you so much for your attention. It was a pleasure to present this to you. And if you have any question, I'll be happy and try to answer it for you.